Right then, we're going to get going. Don't want to hold you from your Friday night any longer. So my name's Mike, and I think I'll just have a quick check of who we've got in. Yeah, hey Tab, how you doing? Yeah, I think I know everyone on here. I think you've all either met me or seen this before. So yeah, we'll forget all the introductions. We'll just get going. So this is the third installment this week. We've got a chap who's got neck pain. He's a mechanic. Hey, Natalie, welcome back. Cool. So I just wanted to let you know I finished teaching on Tuesday this week, the very first UK live stream of taping. So we did an FMT1 course this week, which we did it over several days and did like an hour and a half on each day with homework in between. So trying to work out how we can still deliver proper course content, but just online, and created a Facebook group for the guys that were on the course, and then they had to submit their videos as part of their assessment. So yeah, finished that on Tuesday, and that went really well. So we've decided to do another one and a pods course as well, and so the rock pods is the cupping course, and we the idea is that we rock tape will put available to you guys some patient packs, so you can give codes to your patients for them to buy the kit, and then you can do sessions like this where you can teach them how to use it, and then they can do treatments on themselves with you showing them what to do. So hopefully a way to connect with your patients again online before we actually get physically hands-on again. So hopefully that's something that I think it's already about half full, so it looks as if it's going well. So I'll give you a few more details about that as we go through the coming weeks. But yeah, if you want to book a place, it's on the Rock Tape website. It was just launched the other day. So that's that. Yeah, then we're going to finish off this week. So third session of 3. Like I said before, I'm gonna do next week and then the week after, and then we'll have 10 weeks worth of CPD that I've done, and it's going to be nearly 30 videos, and each video is around about half an hour. So there's a good, well, there will be at least 12 hours worth of CPD that I've put on over the course of this lockdown. So on the COVID-19 group on Facebook, there is a playlist link, so you can click on the playlist link, and it's got all of the videos that we've done throughout the whole of the 8 weeks. Okay, so hey John, good to see you, mate. So plan today then is what do we do? So we've gone through case history. Then we went through in a little bit more details, kind of fine-tooth comb and split things into different areas. And now it's like, well, what the heck do we do? So we're going to go through, because obviously this is fictitious, so we don't know what the outcomes of the tests would be. But if you, this is what you would do if you needed to test everything. Okay, so who would you send people to? What kind of test would they have? All that kind of stuff. So that's what we're looking at today. So these are the key points from the sieve then. So we've got a 55-year-old man. He's worked as a car mechanic since he left school, I think it was. And so the idea with this is that we've got a snapshot of his psychosocial, or the psychosocial aspects of his life. So he's 5'10", and he's 14 stone, which puts him at overweight. He's happily married, got 3 grown-up kids and 5 grandkids, which is really good. So we've got a strong kind of home base by the looks of it. So if we did need him to do any kind of remedial work himself, then he is more likely to be supported by his family. So that's good. Like I said before, it's kind of strange with these OSCEs. Usually they're divorced and got drinking problems, but yeah, this guy is happily married with 3 grown-up kids. He is a bit depressed and guilty because he got diagnosed with the emphysema because he was a heavy smoker, and when he got diagnosed he gave up. So we've got that diagnosis of emphysema there. He's also had an X-ray, I think it was 5 years ago, and it showed moderate degeneration of C5 and C6 in his neck, and those vertebrae, the vertebrae in that region, are usually the ones where if you're going to get any kind of early degenerative changes or normal changes, then it would be that region of the neck, and we assume it's because of the step and the lordosis in that region as it goes into the thoracic. So because of the change in mechanics, it's more likely to have more movement through that area. So again, more changes as you get older. His father had a stroke as well, which was one of the big clues in the case history. He came into work with a flushed. He came into the treatment session with a flushed face, and he has been diagnosed with hypertension. So hypertension is high blood pressure, and so you think, right, okay, it might be that because of his high blood pressure that he's got the red face. But one of the things that was noted in the exam paper, because these are real exam kind of trials, if you like. It was the fact that because he was a car mechanic working indoors all day, and it was an MOT testing centre, so there may have been a risk of carbon monoxide poisoning, and I just thought that was a bit harsh. You know, if you're gonna test people, then that was a real tough one. I would have linked it to the hypertension rather than that, but just to let you know, that's what they were after on this exam. He's on Atenolol, okay, which we're going to talk a little bit more about in a sec. So if you've not heard of that before, then we'll describe what it does and what kind of effects it has on the body. So yeah, he was a heavy smoker. He's now given up, and he was presenting with unilateral neck pain. So neck pain on one side, it was his right side, and the CDJ is the cervico-dorsal junction. So the dorsal is the kind of old school name for the thoracic, so it's CTJ or CDJ, and the posterior shoulder, and tightness around that region. So it seemed to be indicating that there was maybe a trapezius or levator scapular sort of musculoskeletal issue, and his neck feels heavy, exacerbated on end range flexion. So when he went into flexion, then he was getting that tightness a bit more, which is a common one. So one of the things you can do with that really quickly with patients is if they say, oh yeah, I feel really tight in here, and they bring their head down and it makes the tightness worse, then trying to differentiate between a neck problem or a shoulder girdle problem. So you bring the head down, and if that brings on the symptoms, you get them to shrug the shoulders, and if shrugging the shoulders eases the tension, then it's much more likely to be related to the trapezius and the levator scapula rather than a neck issue. Okay, because by lifting the shoulders, by lifting the shoulder girdle, you haven't moved the joints in the neck, and if it eases the symptoms, then it's more likely to be the shoulder girdle rather than the neck. So just a little tip for you. It's a nice, quick, easy one that you can do. There's no sharp pain, which is good, but his pain was worse during activity, which could be muscular fatigue. There was no specific focal dermatomal neurological symptoms. So basically there wasn't any symptoms down his arm in any sort of pattern. Okay, so that was good. Worsening neck and unspecific arm symptoms. Okay, so the things are getting worse, which is not a good sign. And he was also recently, very recently, in the last few days, suffering from vertigo, so dizziness, nauseous, and especially when his neck was in hyperextension. So I can't remember what he was doing. Maybe he was painting something. I can't remember from the case history. But his head was backing up, and in that position, it brought on this dizziness and vertigo and feeling of nausea. Okay, so that was a recap of our guy, and these were the kind of things that we were looking at. So we've got localized cervical joint or muscle irritation, tension, whatever you want to call it. And the reason for that is because they're unilateral symptoms. He was tight on end range flexion, so possibly trapezius or levator scap. So we would do just a normal active, passive, active, resisted examination, and then those little kind of tricks in between and obviously palpation to see which areas were causing his symptoms if you could locate it. So that was easy, yeah. So if it was just a musculoskeletal problem, it was probably something to do with his postural fatigue from work. Okay, so that was nice and easy. He may have cervical stenosis, but so stenosis is a narrowing of the well, it's the symptoms of a narrowing of the foramen. So where the spinal cord goes through the vertebral foramen, if things are starting to change on the front of it, where the vertebral body is, or the back of it, where the ligaments are, and it's encroaching on the space that's available for the spinal cord, but there were no real neurological symptoms with it. So it could possibly be, and the fact that he's had changes at C5, C6 a few years ago, picked up on X-ray, then that, you know, they may have got worse, those changes. So it should be in the back of your mind. So really, that one's a GP referral if you were worried that it could be that. Then we've got TIA or stroke. So TIA is a transient ischemic attack. It's dubbed a mini stroke. So you've got an occlusion for some reason of the blood vessels that supply the brain. So it could be either a full-blown stroke or a TIA, or linked to cardiovascular disease. Okay, and the reasons for that was because of his family history. Yeah, because his dad had a stroke. And he was suffering from nausea, vomiting, and dizziness, and especially on end range extension. So that leads us to believe that it may be something called a VBI, and I'm going to talk a little bit more about that in a sec. So if you did think it was that, if you thought it was a stroke, then you could do a FAST test, so face, arm, speech test. We talked about that before. And you basically get people to smile, and if they can only smile on one side of the face, then that's the face part of the assessment. And then you get them to lift their arms up, and if they can only hold one of their arms up, that's another part. And then speech will be or may be slurred. So if they have any of those symptoms, you should call 999. Facial paralysis, arm weakness on one side, and slurred speech. Okay, and any of those, and that's a 999 job, that one. So depending on what came out of that, so if those are all clear, but then he had a possible VBI, which we'll talk about in a sec, then that's could be a GP visit. It depends on the outcome of the test. So if you're worried, 999. If you were kind of had a little bit of a suspicion, then you would get them checked out by the GP. Then possibly a migraine because of the vertigo, nausea, vomiting. So send him off to the GP. You could check his blood pressure. Anybody with headaches, I always check their blood pressure just to make sure that that's normal. And I think someone mentioned last time on Wednesday about cervicogenic headaches as well. So that could be linked in. So they are headaches from the cervical spine, basically. So the muscles and joints of the neck are causing the symptoms of the headache. Okay, so quite often I get referrals from GPs with patients with cervicogenic headaches. They've had everything else checked. They've had all the scans done, everything's clear, and they're thinking, well, it must be either the muscles or the joints. So that could be it as well. And then there could be an inner ear or vestibular issue because of the dizziness and vertigo. So that's one to send off to the GP. Okay, so those were the kind of things that we were thinking and the reasons why, and then what to do. So I'm just going to break those down a little bit. So there's something called 5 Ds, 3 Ns, and an A. Okay, so if you've done one of my courses before, hopefully you remember this, because we deliver this on all of the cervical spine assessment days. These are the first questions that we ask and first things we look for. If anybody's had any neck pain, it's at the top of our neck checklist form. Okay, so these so your 5 Ds are dizziness or unsteadiness, diplopia, so double vision or visual field loss, so they might have had weird kind of blurry patches in their vision, and it's unusual. Okay, so it's just come on, it's not something that's always been there for life. Dysarthria, dysphasia, so difficulty with speech or finding words. We've got dysphagia, so difficulty swallowing. So they might, when they're drinking, they might cough up the liquid because it feels as if they're choking. Okay, so they may have had a couple of episodes of that in the past, so you need to ask them about that. And then drop attacks, so sudden collapse but without loss of consciousness. So it's not like fainting, where you just fall over and then you black out for a bit, and then once you're down, you back up. You are conscious all the way through the drop attack, and you just hit the deck and you don't know why. Okay, so those are your 5Ds, so you need to look out for those. And on the slide here as well, it's got older patients over 65. So over 65 is a kind of key age range for these potential issues. Okay, and reports of any of the following typical symptoms of VBI. So I'll talk to you a little bit more about what that is in a sec. So these are the things to look out for. So dizziness, diplopia, double vision, difficulty finding words or speaking, difficulty swallowing, and then drop attacks. Okay, those are your 5Ds. 3 N's, nystagmus. So and that's a flickering of the eyes. I'll show you a little video on that in a sec. Nausea and vomiting, and numbness or paresthesia, and this is perioral, so around the mouth. Yeah, so this guy is presenting with quite a few of those 5Ds and 3 Ns. Okay, and the A from the beginning is ataxia, and that's a abnormal gait. Okay, so if you notice that they're stumble, tripping, dizziness, and all this kind of stuff, that's a real red flag for a potential VBI. Okay, so if you've never heard of it before, then this is what it is. It's a vertebral basilar insufficiency. So these are the arteries that supply the brain. Okay, and we did do a little video on this on Wednesday, showing you where they go up in the neck. So from C6 all the way to C1, the side of the vertebra have got holes in. So in the transverse processes, there are little holes, and the blood supply goes up through those holes all the way up and then feeds the brainstem at the base of the skull. Okay, so VBI, usually associated with patients that are 65 years old with cardiovascular risk factors such as hypertension and hypercholesterolemia. So basically high cholesterol and high blood pressure, and a smoking history, which is what this guy's got as well. Okay, so again, tick, tick, tick. However, it can be associated with coronary artery disease, and can occur at any age. All right, so that might be our guy because he's 55. It's also linked to atherosclerosis, DVT, and thrombus, where there was nothing like that mentioned in his history, but he's still got the other things as well. So signs and symptoms, they include dizziness, unsteadiness on the feet, diplopia, dysarthria, dysphagia, and sudden collapse. Okay, so those are 5Ds. Worse when in end range rotation or extension. Yeah, so this is when this comes on. And the reason why is because when you're in that position and then rotated, you can occlude the vertebral artery, and especially with rotation, it can stretch the artery, and then it's like when you bend a tube around a corner, the tube starts to close up a little bit. So if you've already got a restriction there and then you're in that position, it can close it up even more, and then you black out. Okay, so that's a VBI. So these symptoms are the result of inadequate blood supply reaching the hindbrain. So again, it's very much, it looks like a stroke. Yeah, that this kind of thing. There is a clinical test for it, but we recommend not to do it now. So there's a red light there. So if you suspect a VBI and they've got all these symptoms, and then they hit the right age range, they've got all the family history, and they're getting this dizziness and strange, odd sensations, then the last thing you want to do is get them in that position and rotate an extension. Yeah, because you don't want to bring about a lack of blood flow to their brain. Okay, so if you suspect it, you should get them off to hospital. All right, this is one that needs to be checked out by A&E. So yeah, it's again, you can see on the internet there are VBI tests, but on my course, we recommend not doing it. If you think that the suspicion is that you think they've got it, then by doing it, puts them in a vulnerable position, and you could make them worse. So we definitely don't want to do that with this test. Okay, so so that's a VBI. If you've never heard of that, and just before, oh, I've missed one. I thought there was a slide in there. Let me just show you this. Okay, so this is a nice stagmus. Let me just show you this. So this is one of the 3 ends. Okay, so hopefully you saw that. It's a bit freaky. So that was a voluntary nystagmus. So that girl on there, she is able to make her eyes flicker, and which is fine if you can do it. It's not really recommended. But if that is happening when somebody is looking up, yeah. So, but as part of your examination, when you're doing a neck assessment, part of the examination is to go into extension. So if you've got someone like this, or to be honest with you, anybody with neck pain, when they go up into extension, don't just look at the range of movement in their neck, have a look at their eyes as well, and make sure their eyes aren't flicking when they're going into that position, because that's one of the signs of the VBI. Okay, so, and that's called a nystagmus, which is where is it? Yeah, that number 1 of the 3 ends there. Okay, so just to make you aware, that's what that is if you've never heard of it before. Okay, cool. So then we said, okay, do a bit of research into Atenolol, which was the medication that this chap was on. And I can't remember who it was. I think it might have been Natalie. Said that it's a beta blocker, and it is. So beta blockers any beta blocker ends in olol. Okay, so anything with olol on the end is a beta blocker. And this is what they do. So in your heart, you've got B1 receptors in your heart. So it's part of the sympathetic nervous system. So when you release adrenaline, the adrenaline binds to those receptors, they're beta receptors in the heart. Exactly. Beta receptors in the heart, and then it will increase the heart rate and increase the contractility of the heart muscle. Okay, so that's what the beta 1 receptors do in the heart. So adrenaline attaches to those receptors, and then it increases your heart rate. So what a beta blocker does is blocks the beta receptors. Okay, that's basically what it does, and you can get specific, because there are different beta receptors. So there's a 1, 2, and a 3 as far as I know, but the Atenolol only targets beta 1. Okay, so it specifically targets the heart. It's called a selective beta blocker. So when you get a spike in adrenaline, the Atenolol will block the beta receptors so that the adrenaline can't bind to it, so it reduces your heart rate. Okay, so obviously for someone who's got hypertension, high blood pressure, then that's quite useful. Yeah, there are obviously side effects to the medication, but that's basically what it does. So a beta blocker blocks the beta receptor. That's what it does. Okay, here you go. Yeah, so Atenolol belongs to a class of drugs called beta blockers. The beta receptors are found in cells on the heart. So when adrenaline activates a beta receptor, blood pressure and heart rate go up, like I was saying before. So beta blockers prevent adrenaline from affecting beta receptors. This causes blood vessels to relax, and then relaxing them, the beta blockers help to lower blood pressure and reduce chest pain. So that's what it's there for. So it decreases the heart's demand for oxygen. So beta blockers can't permanently change blood pressure, they just help manage the symptoms. Okay, so that's important to know as well. And a really good course that I went on, probably one of the best courses I did, was a phase 4 in cardiac rehab, and went into this in quite a lot of detail. It was a number of years ago that I did it, and you have to do hospital placements as well on the cardiac wards. And yeah, it was really good course. I highly recommend it if you're a fitness professional. Then I think you need to do your GP referral course, and then you're allowed access onto that level 4. But it's definitely worth doing if you're interested in training people who've got heart conditions. Well, it's the course to do. You have to do it. Yeah, highly recommend that one. Cool, and that's it for another week. Thanks everyone. Hopefully you found that useful. If you've heard of VBI before, then apologies, but if you haven't, then hey, there you go, something new, and a little bit of information about some beta blockers as well and what they do. So hopefully you found that worthwhile this week. We've got another OSCE next Monday, so OSCE number 9. I'll see you at 6 o'clock on Monday, and I'm back with Dan. We're talking about back pain assessments at 8 o'clock on Monday evening. Okay, so I'm back Monday 6 p.m. and then Monday at 8 p.m. next week. So I'll see you then. Thanks.